Now we have a very important topic we need to discuss. How should we describe LVH? Because LVH is not always left ventricular hypertrophy. We have here this overview where we can see that we have the left ventricular mass index, which we need first index to body surface area, so gram per square meter, where we have the reference range for females, it's below 95 gram per square meter, so 43 to 95, and for males it's 49 to 115 gram per square meter. And when it's below, we have a normal left ventricular mass index, as seen over here. So in case of the relative wall thickness and the left ventricular mass index, we need formulas. Those formulas you can find in the internet, but I also have a dedicated lecture of left ventricular hypertrophy and hypertrophic cardiomyopathy for you in preparation. So when it's uploaded, you can also watch this video. But it's very important that you differentiate the relative wall thickness. So if it is below or 0.42, we have overall a normal geometry of the left ventricle. For all those measurements and the calculations, we simply need the left ventricular and diastolic diameter. We need the size of the interventricular septum, so the thickness of the interventricular septum, and the thickness of the inferolateral wall. And when we have a relative wall thickness with a normal left ventricular mass, and the relative wall thickness exceeds 0.42, so in this case we have a so-called concentric remodeling. So this is not concentric hypertrophy. Concentric hypertrophy is defined by an increased left ventricular mass index, so for males above 115 grams per square meters and for females above 95 grams per square meter. And here we can see that if the left ventricular cavity is large, we have eccentric hypertrophy. If it is small, we have concentric hypertrophy. So we can differentiate how the left ventricle, how the form of the left ventricle in case of thickened heart valves actually is. And I would stick to this description because it makes a difference in my personal point of view if someone, for example, has remodeling in case of hypertensive heart disease, hypertrophy in case of, for example, in a hypertrophic cardiomyopathy, or also that we should describe as increased thickness of the walls, amyloid heart disease, because amyloid heart disease is an infiltrative disease. So it's different by means of etiology compared to concentric remodeled left ventricle with hypertension or a hypertrophic cardiomyopathy. Continuing with the next clinical phenotype, we now talk about the clinical phenotype 2. So we leave arterial hypertension for a moment and we talk about coronary artery disease. Of course, hypertension is an important risk factor for coronary artery disease, but as a clinical phenotype, here the leading problem is the coronary artery disease. So we have, in this case, very often a microcirculatory problem or inoca, so ischemia with no obstructive coronary artery disease. And we have this microvascular dysfunction. So 2/3 of clinical ischemia, so quite a lot of patients have this microvascular dysfunction. So not an obstruction in a relevant or in a large coronary artery, but of the microvasculature. So it's a very important disease entity we have to think about. This is such an example of strain imaging and ejection fraction. In this patient, we have an ejection fraction of 55%, so it's normal, in the normal range, and a definitely reduced global longitudinal strain with a basal reduction. So we see a basal reduction, also somewhat of a gradient. Also the ventricle, as we see here, is to a certain degree thickened, probably due to hypertension. In strain imaging, we see this bullseye display. We also have a reduction more in the basal segments. Here in the apical segments, we have somewhat of a spared area as well. And we have to note that the global strain, so the global longitudinal strain is minus 15.1%, so definitely in the reduced range of strain imaging.